Wrapping up an incredible day 2 here at the Texas Association of ACOs. It has just been absolutely action-packed. Everybody's in the room, from innovators, investors, digital health, solution providers, ACOs, health system, value-based care continues to expand. All of these people coming together in one room to really focus on the future of healthcare and how we solve this problem of increasing outcomes and decreasing costs. I have the unique opportunity to close out the last session of the day with my dear friend, Dan Roberts from Value Services Management. And Dan, I've always enjoyed the work. I know we've had a lot of great conversations, but tell me, from your perspective, what are some of the key takeaways and kind of nuggets of knowledge you've taken from this conference so far?
Absolutely. John Carter, great to see you. It has been an amazing conference, and one thing has stuck out more than others, it's that the cast is getting wider. And no longer is it going to be value-based care needs to be on the backs of primary care providers. It's been a good growth. It's been a slower growth trying to go that way heavy and towards PCPs. We're seeing more and more specialists get involved. We're seeing tech players get involved. You could say that CMS and CMMI is throwing spaghetti at a wall, but they're trying. And I like that. And the fact that there are these innovative models coming out, it would be an issue if some of them weren't pulled back. And so we saw some models sunsetted, and that was the biggest takeaway that I've seen, is that they've been replaced with ones that aren't trying to just blanket everyone, that there's trying to be true depth to the programs that we have here, understanding how they all work together. And I'm cautiously optimistic this is going to work well.
Yeah, I think it's a great analogy, because I had a conversation earlier, and that was the exact point that I made, is if you look at, value-based care, CMMI got a little bit of a bad rap, right? Because we had 49 models, we only expanded 4, we spent $5 billion more than we saved, and go on and so forth, and the CBO report and blah, blah, blah. And so when they started pulling back these models, people thought that it was an assault on value-based care. My argument was, no, it's a hard reset. And so we've had 10, 12, 13 years now to pressure test these models, and it takes trial and error. But we're taking the best of what's worked, and we're focusing the lens to actually incorporate those best practices. And what I'm seeing is, when I look outside the 4 walls, I see the CMMI strategic refresh, I see the CMMI strategy on data sharing. And then I start to see all of these other models. We've said, hey, value-based care is great. You guys are doing a phenomenal job in the primary care market, but 70 to 80% of the expenditure still sits in the specialty care. And so we have to find ways to either bring them in collaboratively together, or we're going to have to start create specialty-specific models, and more telling, mandatory models, to push people into downside risk. So I think the law of diffusion of innovation, we're past that point of early adopters. We're getting into the early majority. It's picking up speed. It's picking up pace. When you talk about kind of throwing the spaghetti on the wall, I think we're going through the same iteration on the specialty front that we went through with the primary care, because we're not exactly sure what's going to work and what's not going to work. So CJRX is a great example. It's kind of a rebirth of the BIPC and BIPCA program. You look at TEAM, and I look at, well, that's high cost variation in both the case and the post-acute spend. And so that's why those models are coming in from a mandatory perspective. And so we're starting to figure out how to align around specialists, either within the ACOs themselves as a collaborative agreement, or by creating these specialty models that drive synergy to the center. So I love the analogy of throwing the spaghetti. And that's probably a great lead into the good work that you all do. So let's talk a little bit about VSM and the work that you do and some of the ACOs that you help support. And what does that look like at a macro level?
Yeah, at the most macro level, we're an umbrella, right? And so what we do with our umbrella value service managers, we contract in just about any point solution that anyone would need to win at value-based care. But what we do is, under the umbrella, we hang boutique ACOs that we either own or manage. And what makes us unique is that we don't try these big blanket processes. We try to keep things tight. Our goal is to make sure that we, frankly, shut up and listen to our providers and make sure we understand what they know they do well and help fill the gaps. We don't try to bulldoze in and understand from our point of view what needs to happen. We really try to make sure it's something that is going to gain adoption, not something that looks good in an academic sense. So being practical, being real, and keeping those populations together, we've found has helped move the needle. And focusing on the outpatient has been very rewarding for us. But the biggest next wave is definitely really in that post-acute institutionalized patient space. I think that's the last sector of primary care providers that really not been as touched as much in value-based care.
Yeah, no, I love it. And I, what I'm hearing there is Stephen Covey, right? So seek first to understand. And so I think that's a great philosophy, because a lot of times people come in and they say, well, we know what's best, and here's what you need to do, and here's what has to happen. And immediately you start to erode trust. It's like, well, how do you come in and tell me what to do if you haven't taken time to understand our operating environment and how we do things and what's going to make this better? And so one, I appreciate that. And two, you talked about the umbrella and then kind of underneath the tuck in from some of these more boutique ACOs, one of which being kind of that institutionalized patient. So let's talk about the long-term ACOs. I think there's a tremendous amount of opportunity, and you guys kind of charged into that space and said, we're going to try to figure it out because this is an area that's been missed and we want to see how it's going to work. So how's that experience been, and what are some of the lessons that you've learned?
It's been an amazing problem-solving exercise because, frankly, it is different. It is a different population. It is a different benchmark. It's a bunch of different things on paper, but in practice, it is completely different than what we'd see in the outpatient side of house. You don't need care coordination teams to call, to schedule patients, to have them come in. You've got the captive audience. They're in the assisted living facilities. It's much more about optimizing the provider's time, making sure that they're getting what they need, making sure that when those providers that are not on site, so you have days sometimes where there's no clinical staff in an assisted living facility, setting up that safety net to make sure that patients don't default to the emergency room. These are true change management 101 things that, again, you have to listen to the baseline of what's happening to understand how to influence change.
I love it. So you couldn't take the same old operating model that we found successful in traditional value-based care ACO operations and apply it over the top. So going back to first understanding, and those are the lessons that you've learned, and now you've somewhat, I wouldn't say perfected, but you've really streamlined that model and you're starting to see returns on that investment?
Constantly learning, absolutely. But that is the biggest thing that we have seen is partnering with providers that also need to please the facilities and remembering that what has to be good for the collective is the path forward. We cannot do one to spite the other. At the end of the day, yes, we contract directly with the providers, but we have to recognize that what is most important to us at the ACO level is not going to be the most important thing to them. Again, we need to understand how we fit into their ecosystem to be able to succeed together.
Kind of tying this back to some of the other things we talked about with team, right? And so we talk about the variation in post-acute spend. And what I've said is we've got to bring them in as care partners, and we have to understand the risk. We have to share in the risk, but we have to share in the reward. And so you can't just look at these SNFs and other entities as discharge destinations. They have to be a continuation of the care path. And I think that's where that continuity and collaborative working relationship comes to bear fruit. And then the models that you're able to wrap around those institutionalized patients, I think has been a real win.
If you treat them like a cost center, they'll act like a cost center. If you treat them like a partner, they'll act like a partner.
Yeah, I love it. I love it. Well, it's been really exciting. I know there's a lot of new models that are out there. Some of this can somewhat make your brain hurt, but going back to we got to test it, we got to figure it out. I've been really intrigued by the access. I think we were all woefully underprepared or underwhelmed, I should say, with the outcomes-based payment. But the government saying, "Hey, we're actually going to reward outcomes," is a telling sign in terms of reading the tea leaves.
Yeah.
You look at LEAD and it's like, okay, well, REACH needed to do something, but a 10-year runway tells me that there's a long-term longitudinal path for how we maintain those relationships. And so we're investing in the long term. We're investing in outcomes. We're starting to shift the model. We're starting to force more downside risk. We're either going to get ahead and start figuring out how to operate in risk collectively together, or the government's saying we might force you into risk and you need to be prepared. That runway seems to be getting shorter and shorter by the day. How have those conversations gone for you and your clients?
It's to your point. It's forcing towards risk. It's forcing to have skin in the game. And in our mind, it's forcing efficiency. So I heard what you said about the access rates being low and agree, but I took that as more of a signal that we need to act more clear and efficient in our time and our labor. So this is not a double on CCM. This is for that rising risk population. And it's for those that are not so complex. They need the human intervention. Yeah. The whole point is to have an AI first approach to manage that and take pulse before they climb the pyramid, have that more acute event and need the human intervention.
Yeah, so broaden the base, right? Because we're already in a workforce shortage. Broaden the base, create efficiencies from administrative burden, use AI to tighten up workflows if you understand the workflows, because my experience is AI just amplifies dysfunction if there's already dysfunction there. So understanding the workflows, and then so you've got a broader base, you've got more efficiency, you've got more streamlined communications and intel, and then being able to manage that rising risk to reduce them kind of going off the cost curve, correct?
Yeah. And to your point about dysfunction, it's like Dr. Bricker said in his keynote address. It's people, process, and technology, but in that order.
Yes, got to have the people first. Gosh, I love Dr. Bricker. I've been following him for years. I was so stoked we got him as the morning keynote, and he delivers. He always delivers. It's been great.
It was confusing not seeing with a whiteboard behind him, but yes, the message was still there.
Yeah, a marker like, hey, can you just start jotting this down instead of using the PowerPoint? That's awesome. Well, man, it's always great to see you. It's just been phenomenal to kind of spend time here. I know we're getting dangerously close. I hear it starting to trickle over to the party. So let's go have some Taco Tuesday, some margaritas, and a special surprise most of the guests don't know about is we also have a mariachi band coming today. So we're about to have a whole lot of fun, and the networking is where the action happens, where the connections are made. and then the rest of it is driving the business and the performance. So Dan, thanks so much for joining me, and it's just been a great conversation. I'm looking forward to the next one, and let's move healthcare forward together. Thanks so much.
Awesome. Appreciate you, John.
Yeah.
Thank you.
Awesome.
Pinnacle is your partner in the business of healthcare, nationally recognized for helping clients manage risk, improve performance, and drive innovation. For more information, visit our website, askphc.com. For more information on our guest or to learn more, please visit their website.